Well, it's my great pleasure. It's my great pleasure to introduce Dr. Sarah Ibrahim to you all. She's a scientific associate in the program for health system and technology evaluation in the Toronto General Research Institute and a quality improvement innovation educator in the J and Sari Sonshine Center for Stroke Prevention and Cerebrovascular Brain Health at Toronto Western Hospital, University Health Network. Sarah is also a certified healthcare simulation educator, a research member in the Center for Advancing Collaborative Healthcare and Education at the University of Toronto, and a section editor with the Canadian Medical Education Journal. She was an assistant professor and teaching stream in the Lawrence Bloomberg Faculty of Nursing, and she's had the privilege of being mentored by well-renowned researcher and has held various positions such as the clinical research educator, research nurse, research consultant, scientific writer, Canada Research Chair trainee, and investigator. And the focus of Sarah's research and QI initiatives is in implementation science with the broad goal of designing, implementing, and evaluating simple and complex education and health-based interdisciplinary interventions that optimize care delivery processes, improve patient health outcomes, and translate evidence into meaningful guidelines and initiatives. And lastly, Sarah is also the Health Services Management Officer in the Canadian Armed Forces, in a medical reserve unit where she has held various positions in operations, platoon commander, and is spearheading simulation research and scholarship in the Canadian Forces Health Services. So we're so lucky to have Sarah on board, and it's been a wonderful experience for me to work with Sarah over the past 6 months. So I'm very excited to hear her talk today.
Thank you so much, Sanjula, for the introductions, and thank you everybody for having me. So the title of my presentation is No Brain Embrace Care, a Mixed Method Study. The objectives for today's session is to describe the purpose of the No Brain Embrace Care study, to present the study findings, and conclude the presentation with a discussion of the study implications and the next steps. The global incidence of stroke has increased by approximately 70% from 1990 to 2019, with approximately 12.2 million new cases of stroke per year. And interestingly, there's a misconception that stroke is a disease of older adults. However, we're seeing an increase in stroke incidence, about 40% in younger adults worldwide. Stroke has been linked to non-modifiable risk factors such as our age, genetics, as well as modifiable risk factors and psychosocial factors such as depression, perceived stress. Stroke has been linked to 10 modifiable risk factors collectively, and they've been associated with 90% of the population attributable stroke. And so as you can see here in the image, some of the modifiable risk factors include smoking, alcohol use, substance use, poor diet, and low physical activity. Adherence to a healthy lifestyle is critical to be able to prevent stroke from a primary and secondary stroke prevention, highlighting the importance of focusing on healthy lifestyle as part of our care. Lifestyle medicine is a clinical evidence-based discipline that applies the principles of motivational, environmental, medical, as well as behavioral principles in order to be able to address the complexities, that is the modifiable risk factors of chronic disease. So lifestyle medicine has its roots from as early as the 1970s, and it has grown quite substantially and gained momentum from the Lifestyle Heart trial that was led by Dr. Dean Ornish in the 1980s. And so with this trial, he was able to find that adherence to a non-pharmacological and intensive lifestyle modification intervention reversed patients' coronary artery disease at 1 year as well as at 5-year follow-up. And so over time, and with the evolution of this trial and the associated research, cardiac patients in the United States now have access to the Ornish Intensive Care Rehabilitation Program through Medicare. Lifestyle medicine is said to be the cornerstone of health as well as well-being. So there's very few studies that have investigated lifestyle medicine-related knowledge and behaviors among younger adult stroke patients. And here in Canada, there are no studies that have been conducted that investigates younger adult stroke patients' lifestyle medicine-related knowledge, their behavior, as well as facilitators and barriers to be able to support the adoption and engagement of such habits and behaviors. And this understanding is critical in order for us to be able to identify knowledge gaps in this patient population, to understand the facilitators and barriers with engaging in this type of lifestyle, and in turn inform targeted lifestyle medicine educational efforts and interventions with the intent and hope to improve risk factor modification. As such, our study aims was to assess younger adult patients that are seen both at the stroke prevention clinic and the neurovascular clinic at Toronto Western Hospital, which is a very large institution here in Toronto that provides care to stroke patients as well as individuals with various neurological conditions. And the aims was to be able to look at and assess their lifestyle-related knowledge and behaviors, factors and facilitators and barriers that influence their adoption in healthy lifestyle. And finally, their overall brain health experiences, their perspectives on lifestyle medicine, and preferences with post-stroke interventions and initiatives, with a keen attention to gender differences. We employed an explanatory sequential mixed methods design, and our first phase was the quantitative phase. And in this phase, we used validated scales through a red cap survey. And the purpose of the phase was to simply assess their knowledge and behaviors and identify and understand facilitators and barriers to the adoption of their lifestyle habits. Phase 2 was a qualitative phase, and this followed suit after completion of the quantitative phase. And this is where we conducted semi-structured focus groups with mixed gender participants, so it was groups of individuals that identified as men and women, and also semi-structured focus groups with individuals that identified only as women. And so the purpose of the qualitative phase of this study was to be able to attain an in-depth exploration of their views, their perspectives, understanding of brain health, and also their recommendations for how we can design post-stroke interventions and initiatives that meet their needs. For our data analysis for the first phase, we conducted descriptive and inferential statistics, and the qualitative phase, we employed a thematic analysis using Braun and Clark's 6-step process. So I'll begin by presenting our findings from phase 1, that is the quantitative results. We had a total of 104 participants take part in the quantitative phase. Approximately 54% had a stroke and 29% were diagnosed with a neurological disease. The majority of the participants were women, so it was about 52% with an average age of 47.5 years. Majority of the participants were married and had a college and university level of education. And they had indicated that English was their first language, and the majority of participants identified as white. With respect to the lifestyle medicine related knowledge, we found that individuals had an understanding of the blood pressure, of recommended sleep per night, as well as alcohol and consumption per day. However, where we saw a lot of the gaps in knowledge was with respect to physical activity, the recommendations for the servings for fruit and vegetable intake, for lean protein intake, for whole grain intake, and sodium intake. So really it falls under the physical activity domain as well as the nutrition domain. Interestingly, we did see some gaps and differences in age-related knowledge. So for example, individuals that were 45 years of age or under 45 years of age had higher knowledge around the recommended servings for lean protein in comparison to individuals that were over 45 years of age. We found that women had higher knowledge about fruit and vegetable as well as lean protein serving recommendations compared to men as well as the one non-binary participant. With respect to stroke, patients with stroke had a higher knowledge of physical activity recommendations in comparison to those that did not have a stroke. Here, what I've kind of presented falls under the 6 pillars of lifestyle medicine, with substance use not included, primarily because not a lot of the participants were using substance use. So here what we see with the nutrition is that about 67% of the participants indicated eating processed food, and about 18% only ate the recommended fruit and vegetable serving. And some of the factors that influenced and impacted participants' eating habits centered around their anxiety, their stress levels, the amount of time it takes to prepare meals, as well as nutrition labels. Moving into the physical activity pillar, approximately 19% of the participants indicated engaging in vigorous physical activity for about 30 minutes or more per week. 36% engaged in moderate physical activity, and most had indicated walking for more than 30 minutes per week. Some of the physical activity related barriers that participants indicated pertain to their energy, their time, their work responsibilities, as well as safety concerns. Moving into the sleep pillar, we had many of the participants, so half of them actually slept less than 7 hours per night. And with respect to stress, this was quite an interesting finding. 63% reported moderate to high levels of stress, and 44% had indicated feeling nervous and anxious several days of the week. And some of the coping strategies that they employed was the engagement in physical activity, socializing with family and friends, also food, so whether it be eating too much or eating too little, and also watching TV and playing video games. And finally, with respect to the social connections pillar, majority of the participants felt that they had meaning and purpose in life, and that they had more than two other people beyond their family and that were part of their life. We did see some differences as well with the lifestyle medicine related behaviors. So individuals that were 45 years of age or less had higher consumption of processed food and sugary drinks, and they relied more on that. Their emotions also influence their eating habits. So, for example, sadness, anxiety, as well as boredom. And individuals that were 45 years of age and younger actually engaged in more physical activity. However, energy levels, as well as time and fear, were more barriers for this group of participants. And finally, the individuals that were 45 years of age and younger actually coped with stress through counseling, socializing with family and friends, as well as substance use, versus individuals that were over 45 years of age. With respect to the gender differences, we found that more women relied on packaged and fast food, and they had a negative relationship with food, and their emotions impacted their eating habits. As well, women coped with stress through journaling, counseling, as well as socializing with family and friends in comparison to men and the one non-binary participant. And finally, with respect to the stroke differences, we found that an individual that had a stroke coped with stress through the engagement in physical activity, and they also engaged in more moderate physical activity and walking in comparison to individuals that did not have a stroke. Moving now into our second phase, which is the qualitative results. What I'm going to be presenting is our findings from the mixed gender focus group. We're still in the process of analyzing our data for the women's only focus group. We had a total of 12 participants take part in the mixed gender focus group, with the majority being men and about 45 years in terms of the mean age. Majority of them had a college and university level of education. Majority of them indicated or identifying as white with English as their first language, and 83% had a stroke. So we had a total of 6 themes that emerged from the mixed gender focus group. So the first theme pertained to lifestyle medicine. The participants' perception of a healthy lifestyle actually was found to be aligned with the 6 pillars of lifestyle medicine. So this included reducing their consumption of processed food, foods that are high in sugar, engaging in physical activity, reducing their stress through different strategies, trying to be able to attain 7 to 8 hours of sleep per night, as well as reducing their alcohol consumption and surrounding themselves with persons that are important to them. The second theme is Life 2.0, and this was actually the language that was used by the participants in the focus group. And Life 2.0 theme centered around finding that new sense of self-identity and purpose post-stroke, appreciating that many of them were unable to return to work and did not want to, as the language that they use, come out again, after having this stroke, to many people that they don't know. So many participants indicated that frustration of sometimes having to tell people of their stroke in order for them to slow down with their speech, and sometimes feeling as an outsider as a result. And one of the participants indicated, this was a direct quote, people only see kind of the tip of the iceberg and don't see how you're keeping it all together underneath. The third theme is entitled Standard Stroke Care, but to whose standards? So many of the participants felt that the current stroke practice and model of care was very non-personalized, and they perceived it as a simple checklist that the provider would go through. For example, many of the participants indicated that they lost their driver's license simply because it was the standard and protocol, but in fact, they did not need to lose their license, and they had to navigate through many hurdles to be able to get their license back. Participants also felt that they were left to their own devices post-stroke with very little guidance. And the guidance that was provided wasn't very much geared toward younger adults. One participant had indicated that the medical team was great at explaining the physiological and biological components of stroke and what has happened to their brain, but the emotional and the psychological components, they were left to their own devices. And they indicated that this was a huge component of the residual effects of having a stroke and the associated brain injury. Participants also indicated that the current stroke care and language was very much geared towards older adults, with very little attention on younger adults, their needs, and their interests and their goals. So, for example, being able to return to work. The fourth theme centered around how we can innovate post-stroke care for younger adults. And so they recommended having more focus on the psychosocial and emotional aspects, as well as the ability to return to work. And they preferred that these interventions and programs be peer-led so that they have more of that connection with individuals that have gone through a similar experience. And they had indicated that the preference for the delivery of these programs and interventions would be through a hybrid and virtual format simply for convenience purposes. The fifth theme is a dualism of social influence. So this was a very interesting findings because participants had indicated that the social aspect of their life influenced them both in a negative as well as a positive way. So from a negative perspective, sometimes they said that it would influence their eating habits in a negative manner. So they would end up eating more, they would eat more processed food, they would consume more alcohol. And then from that positive lens of it, they indicated that they had great role models and having the support from beginning throughout the entire process. And many of the family members and friends actually adopted changes in behaviors with them to be able to support the participants' recovery. The third and final theme centered around the pressures of being a man. And so this was the gender experiences that came out in the themes. So here, several participants indicated that post-stroke, it negatively impacted their finances and their financial ability because many of them were not able to return to work. And it had negative implications on their personal life. For example, it impacted their dating life because that required some finances to be able to go out and engage in different activities with partners. And so some of them had indicated that they really gave up on trying to find a partner because of the financial implications. Many of them also indicated that they were unable to work, and so they were relying more on their spouses. And this impacted their self-esteem, particularly with the societal pressures and the gender norms. And so it was hard for some of them to be able to speak to this. And they had indicated that they felt always judged by some of their spouses, friends, and family members, even though these were things beyond their control. So the key summary findings from the phases is that majority of the participants understood the current blood pressure, sleep, and substance use recommendations. And I think one of the influencing factors to this is, at least here in Canada, there's a lot of advertisement and education, in local transit and other means to be able to educate individuals on this. But we did find that there were gaps in knowledge with respect to physical activity as well as nutrition recommendations. And what we did see was that knowing about some of the healthy habits did not necessarily translate into practicing the healthy behaviors. And so this is where we found that gap between knowledge and actually adopting some of the behaviors. We also found that there is a need to find a new identity post-stroke. And so that comes with part of redefining our standard of post-care, our models of care, and what we focus on in some of these interventions and programs that really is tailored more towards younger adults' needs. So returning to work, the psychosocial, the emotional aspect, and really trying to see how we can address some of the barriers experienced by the participants to be able to support that behavioral adoption. So with respect to the study implications, this highlights the need for innovative ways to be able to bridge that knowledge and behavior gap for this unique patient population. And it provides valuable insight to us in terms of young adults' current brain health and lifestyle medicine related knowledge, their barriers, so that can help us think through how we're going to develop different interventions and programs. And as we can appreciate from the findings, there's a myriad of barriers that exist that may hinder this younger population from incorporating certain recommendations in their daily lives. And the findings will be informing the development of patient-informed stroke prevention-related education. And we have several patient providers that we will be working with to help ensure that the educational initiatives are really geared towards their needs, and it is informed and driven by them rather than us as the clinicians and researchers. And we're also looking at developing interventions that focus more on that psychosocial, emotional, and ability to return to work components that were identified from the participants. And we're hoping that with these educational initiatives and interventions, with time, as we pilot test them and evaluate them in a more robust way, we can start to translate some of these educational initiatives into different languages to meet larger participants and group of populations that are affected by stroke and neurovascular conditions. I would like to take this opportunity to sincerely thank our participants. We're unable to do the work without their participation in the research team that helped with the recruitments, with the data analysis, as well as helping us with the knowledge translation initiatives, and our incredible collaborators such as Sanjula from the McCance Center that have been helping with the data analysis as well as the manuscript write-up for the work. And we did receive funding for this project from the University of Toronto Slayman Fast Initiative Award. Thank you very much for your time and attention. And here's just a list of the references that were used throughout this project or in the slide deck. I'll stop sharing my screen. How's that?
Amazing. So are there any questions? Eugene, you have a question. You have your hand up.
Yes, thank you for that very nice presentation. It was a lot of information.
Yes.
In one of your first slides around some of the barriers from the phase 1 part of your study, you had a column with nutrition and some of the obstacles or barriers there, but I didn't see anything related to cost of foods. I wonder if in your analysis you came across any feedback from these participants about cost for foods and whether something like the SNAP program in the US would be something that would be potentially of importance, I guess, in Canada.
That's an excellent observation and question, Jean. So cost did not come out in the qualitative phase, and we didn't collect any information on that. But I will preface that one of the limitations of the study is that we had individuals that were of higher socioeconomic status that took part in the study. And so that might be one of the factors and reasons why that wasn't brought up or came forward with our findings. But I think that's an excellent point. And I think if we were able to recruit individuals of more diverse socioeconomic status, that challenge and theme might have come up.
Thank you.
Yeah.
Are there any other questions?
Sarah, congratulations. This was
Thank you.
really thought-provoking, and it is where, as we've discussed, the research really needs to go if we're going to bridge this no-do gap, to quote Nirupama's phrase. And one of the things that struck me as I was listening to your presentation is that many of the concerns raised by the younger stroke patients in your sample echo the concerns raised by, I guess we would call them, older stroke patients in my practice. So it does, I think it's important to remember that a lot of these challenges are sort of generic, but sometimes it's the younger patients who are more willing or able to articulate them. And I'm thinking in particular about the dating implications. So I have found that I really have to extract that from my older stroke patients, but it's a very, very common concern. And I can't recall how you put it, but this notion of treaters and others only seeing the very surface of the impact of the stroke, that to me seems like a universal concern. So sort of thinking about how you could leverage what we're learning to cross the threshold of engagement. Was there anything that stood out as particularly opportune to you if you were to design an intervention based on what you've learned?
I think for me that peer-led interventions is really important and I think quite unique. And it was a very, it came in every focus group when I was immersing myself in the analysis. Many of them very much appreciate the incredible medical care that they get, but they feel that they can't connect with the clinicians because they have different experiences. And so for them, that peer-led approach was really important to them so that they can have that shared lived experience with other individuals that have gone through the similar experience. And so one of the participants, I remember in the quote, said, I don't know what I was feeling was, is it normal? Is it not normal, when they were discharged home? And so being able to connect with others to understand, is this feeling of anxiety, am I going to have another stroke in a week, normal? The depression, that loss of confidence and the self-esteem that's been impacted, having to have those conversations with somebody that is similar in age and that have gone through that experience was something that they really yearned for. And even if it was just once a month, it wasn't something that they needed on a weekly basis, but just something that they could connect with others and learn, what worked for Sarah versus what worked for another participant, and how they can take some of these and try to test them out for themselves.
Were these groups virtual or in person?
They were virtual focus groups.
Well, if nobody else has a question, I'd like to ask another. Have you thought about whether it might be combining the peer experience into the direct administration of medical care could be fruitful and efficient, along the lines of what we're calling in Boston virtual group visits?
Yes, absolutely. So even kind of relaying back to one of our first needs assessments, many of them wanted a group-based, peer-led, but also healthcare provider-led. So that kind of combination of a healthcare provider and a peer-led. So they still have that medical education and they can ask certain medical questions and have those questions answered, and then have that peer aspect. So having, a virtual group-based approach where you have a healthcare provider and a peer that has had that shared lived experience, I think would be a very creative way to be able to meet their psychosocial, emotional needs, but also their medical needs. And so we're looking into something like that as part of our next steps, and looking at alternative models of care that combine group-based approach and through peer-led and healthcare provider-led.
Alex, I believe you have a question as well.
Yeah, hi Sarah, great talk. One question I had was, did you look into, obviously these patients had their stroke at different time points. Someone might have had it like a week ago or a month ago. Did you find that more young stroke patients struggled with the pillars of health shortly after their stroke, or basically did you take into account when they had their stroke?
That's an excellent question, Alex. So we had, as part of our inclusion criteria, it had to be more than about 90 days post-stroke, recognizing that at the time it's quite scary and very complex when they first have their stroke, and we didn't want to overwhelm them with research. But you're absolutely right. And, you're thinking, somebody that's had a stroke 90 days post-stroke, or perhaps 3-4 months, may impact their responses, their experiences differently. And so that's something that we certainly are going to look into and consider when we continue to analyze our data.
Great, thank you.
You're welcome.
Are there any other questions?
Sarah, are you able to see the chat? You can see the
Oh,
comment from
how do I
Zaina.
see? Oh, thank you so
received-
much, Dina.
Yeah, not a question, but just she likes.
I have to say, participating in the focus groups was a very humbling experience. I'll be very honest, I cried after one of them because it was very humbling to really hear their experiences, to hear their challenges, and it kind of gives that purpose and meaning for our work that numbers, sometimes quantitative research, doesn't capture. And so it was a very humbling experience, and I'm very much looking forward to the initiatives that we can do to really help support this unique patient population.
Actually, Sarah, now that she put me on the spot, I commend you for going there, because often, kind of, as brain doctors, it is more like a checklist and more as a quantitative. And at the end of the day, it's the qualitative that matter, especially that the sequelae could very well be chronic, and for those people. So this is all what matters to them. So thank you so much. It's very, very interesting, but also very rich.
Thank you.
Congratulations.
Sarah, I would just add, as you know, Nirupama Yahor, who I can't see on the, oh yes, she's here, is leading a multi-site initiative in the US focusing on well-being in this case, hemorrhagic stroke survivors. One of the questions that your data raised for me is, are we even conceiving of how, do we even understand the values of our patients? Are you just starting to scratch the surface? And, maybe we develop these close relationships in the office and we're able to get at some of this, but, we rarely talk about these issues at, national meetings or in terms of how to study and leverage them for helping people. And yet we've gone on for decades without really tackling these risk factors. So clearly this is really important and it has to be the next phase of research.
Thank you. And just as I was analyzing some of the women's only focus groups, one of the themes that I'm seeing, or the patterns, is the need to also educate beyond the patient. So many of them are young moms, and so they're struggling, having to find that new identity as a mom and providing care for young children. So there's also that need to kind of expand that education to the children and helping them understand what is mom's going through, what has happened to mom's brain, so that they can work with their parents to kind of, as part of that trajectory and that journey of healing.
I think if there are no other questions, Jean, shall we finish a little bit earlier today? Then
Yeah, I
thank you
think
for
that
sharing.
I agree. I think that would work out. I just wanted to mention there's another comment, just some more accolades actually, Sarah, in the chat box. Just make sure.
Thank you.
Yeah.
Thank you. Thank you. I just want to thank everybody for the opportunity to present, and also thank Alexandra, who's also online, for stepping out. I know you're busy in clinic, but thank you for taking the time, and it's an absolute pleasure and privilege to be able to present our work here at the center.
Thank you so much, Sarah, for a wonderful presentation, and I'm sure we'll hear from you again.
Thank you so much. Have a good day, everyone.
Thank you,
Thank
Sarah.
you.
Thanks, everybody. Bye-bye.
Bye.